This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I'm sitting here this afternoon with Dr. Mary Fallett, who is one of our CSAP 17 authors. Mary, before we get started, can you share with our audience where you are located, your primary focus of your clinical practice, and maybe a little bit about how you spend your usual day or week, if there ever is one of those?
Well, I am a pediatric surgeon. I practice in Louisville, Kentucky, where I am a professor of surgery. I am the current division chief of pediatric surgery, and I'm also the surgeon-in-chief for Norton Children's Hospital, which is our full-service children's hospital in Louisville. So my day is different depending on whether or not I'm on call and doing clinical care or in the office seeing patients and operating. But a large part of my time is occupied by meetings, running the division, and dealing with the endless stream of things that come in, not necessarily as complaints, sometimes good things, but the daily things that you have to deal with that are administrative and troubleshooting and strategic things that help the hospital. And it's been a great career. I've been here my entire career, and I actually trained here in general surgery and then went to Washington to do pediatric surgery, but I've been back here, and I've been in practice almost 35 years.
Okay. I thank you for that. And this afternoon, I've asked you to share some of your thoughts regarding mostly topics from the ethics category of CSAP 17. I'm also going to lean on your expertise as a pediatric surgeon for some conditions a general surgeon may face with a child. Most of the topics do come from CSAP 17 questions, although others are questions that may not have been selected for the final draft of CSAP 17, but they've stuck in my mind because there was a lot of discussion among the committee as the question was developed. So anyway, that's my plan, and let's get started. Let's talk about principles that underpin medical ethics, and I would ask you to give us your take on autonomy, beneficence, non-malfeasance, and justice. We have a couple of great critiques that say these are the four that are the foundation. Is that correct?
Traditionally, that is correct. So I thought I would not only define it, but try to give an example of it in medical practice that might help the listeners understand it a little better. So autonomy is really the ability to make a fully informed decision, and it means that you need to understand the risks and benefits of the procedure and the likelihood of success. And if you think about male circumcision in the United States, this is typically done in an infant, and there are potential benefits to doing circumcisions, but they occur later in life, such as the reduction of the transmission of sexually transmitted diseases, which can impact the incidence of cervical cancer and the incidence of penile cancer. But these, of course, are things that don't necessarily occur often in the United States. They occur more often in third world countries. And if you do an infant circumcision, you are robbing that baby of their ability to be autonomous or to make their own decision, and they may grow up and decide that it was the incorrect decision for them. Beneficence requires the intention of doing good for the patient, which is something that we all want to do, but it also means that we have to understand a procedure, maintain our skills and knowledge, continually update training, be lifelong learners. a classic example of how we may have failed to do that, but we're doing a better job now, was the early adoption of laparoscopic cholecystectomy, when the risk of injuring the common duct was perhaps appreciated, but people still felt they had the surgical courage to go ahead and do that procedure, and there was an increased incidence of common bile duct injury that is decreasing as people gain expertise and as the training has become safer and probably of better quality. The next is non-malfeasance. This is to do no harm. And we'll talk about this a little bit later in the hour, but this is perhaps exemplified by recognizing when someone has terminal cancer or life-limiting disease and that the treatments that you are rendering are no longer beneficial and you should have a different plan. And justice is the idea that the burdens or benefits of treatments must be distributed equally among all groups in society. So here a good example is assisted reproduction techniques. So really that treatment is not equally available to all people because they don't have the resources. It isn't something that is paid for by insurance in all circumstances. And so this is, again, a treatment that may not be equitable.
When we have been talking about disparity in care lately throughout medicine, you mentioned access to care, and people use the word equity. Is that really a reference back to justice?
It is. So we should, as healthcare providers, consider fair distribution of resources, competing needs of populations, the rights and obligations of us to provide that equitable care. And then sometimes that may present a conflict with laws or other things that prevail. But there certainly are a lot of examples in society where there is not a fair distribution of medical care or resources depending on where you live, geographically disparate areas, and access to care.
There are two other terms. There were some very interesting discussion among the CSAP committees that are not in this set of four, and those two terms are competency and capacity. And I will say the discussion was very robust. So how do these two terms interact with the four we just discussed, or are they totally separate?
They're probably not totally separate, but one is a legal term and one is something that we use in practice. So competence is the legal term and capacity is the ability to give informed consent for medical treatment, as we would establish that when we speak with someone. If a provider feels that someone lacks capacity, we sometimes confuse that with competence, and we may, for example, consult a psychiatrist and frame it as, is Mr. Smith competent to refuse surgery? Well, that's not really what we're asking. We're really asking, do they have the capacity? Do they have some issue, comorbidity, mental illness, mental retardation, or another mental condition, or something that does not allow them to understand what treatment will be provided, and so they cannot make their own decision. And if there is a difference of opinion between family members and the patient and there's no advanced care directive, then only a court can make a determination of incompetence. So it would go to the court to determine whether or not that patient was competent to sign their own consent or make their own decision. And so one is something we use at the bedside in the hospital, and one is a legal concept that requires a court decision.
Now, one of the discussions was that capacity is most closely related to autonomy. Would you agree with that statement?
Yes, and that might be something that becomes a conflict if there's a appeal on the part of the family that the person lacks capacity to make their own decision because they differ in their opinion about what should be done. For example, if a patient decides that they do not want to seek treatment, but the family feels that they should, they might make a case that their dad or their husband lacks capacity to make their own decision. And so that would rob the patient of their autonomy if they in fact did have the capacity to make the decision. And this is where you might find that you would be asking for consultation from a forensic psychiatrist, which is actually the type of psychiatrist who would get involved in this type of discussion.
And you kind of said it, that capacity is something we use at the bedside. So is this really an understanding between the patient and the physician at the bedside? And are there tests or tools that can be used to help the physician and the patient accept that they have capacity, and maybe the family too?
That's a great question. So really, any physician can make a determination of capacity if they feel that they have a patient who understands the discussion of surgery or no surgery, the risks, the benefits, etc. And if they feel that that patient has capacity, then the patient can give informed consent for the procedure. If there's any doubt, that's when you turn to the psychiatric consultation, and that individual has the expertise and the tools to determine if the patient does have capacity. So it's an opinion, though. So it results in opinion about whether or not the patient can sign their own informed consent or whether you need to move to a court decision.
Let me just ask a very practical question. Have you been in the situation where you're stuck between a family, a patient, and a psychiatrist, where patient, you believe capacity is present and the psychiatrist says, no, it's not?
In my situation, dealing with children, it's more that you may have divorced parents with different opinions about what should be done, and then you sometimes have to seek an outside opinion because you can't get consensus. I wouldn't have that type of conversation with a patient because my patients typically can't give informed consent. Their parents give informed permission for me to do surgery, which is a little different than consent, which is why it's informed permission, because they're acting in the best interests of their child.
I think we'll come back to competency a little bit later, but I'm going to expand on your pediatric experience and ask how competency and capacity play out in an emancipated minor.
So an emancipated minor is someone who is living on their own, married, potentially has a child, or is living independently, might apply in the military, so they might be 17 and have already enlisted in the military. And here there are state laws that help guide us as to what the definition is of an emancipated minor, so you really have to look within the state to get guidance and then consult with your legal division at your hospital also. But if a minor is emancipated, then technically they can give informed consent for a procedure. I think it gets a little tricky when you have, for example, a 14-year-old who delivered a premature baby, and you are having what needs to be a sophisticated discussion with someone who really is childlike in some ways. And we try our best to have an adult figure present, someone who would give informed consent for that mother with us when we're having a discussion. Sometimes there is actually, through social services in the courts, there's a legal transfer of guardianship, but most of the time the parent signs the informed consent for the child. So it's almost like children consenting for babies, which makes us a little uncomfortable at times. But, the fact of the matter is this is the parent, and therefore they are an emancipated minor with respect to that child that they've delivered.
When I hear this discussion, I hear shared decision-making going on a lot. Is that a fair statement?
Yes. Well, yes and no. So shared decision-making is really where patients, families, and physicians work together to make decisions and select tests or treatments or care plans that are based on clinical evidence that balance risks and outcomes with patient preferences and values. And it is most appropriate when there's more than one option for care, such as screening or a treatment decision, or when no one option has a clear advantage, or when the possible benefits and harms of each option might affect the patient differently. And then it's an ability to sit down and have a full discussion of what the patient's condition is, and if you did these different routes of treatment, what the outcomes might be and how that might differ or be the same. And also looking at quality of life and family outlook, etc., so that everybody participates in the decision and everyone's comfortable with the decision. And I'm not sure that what we just talked about would be really shared decision-making, because I'm still going to be an advocate for that newborn in terms of what I think the right thing to do is, even though I'm having a discussion with the neonate's mother and grandmother or whatever the case may be. I'm still probably advocating for a certain choice that would be in the child's best interest, unless I think that there might be some element of futility or, life limitation, or if the choice that is made might create an outlook for the child that really affects the quality of life of the entire family unit. For example, the choice in a 25-week estimated gestational age with necrotizing enterocolitis to take out most of the gut and render that child with short gut, but, looking at a lifetime of TPN and the complications of that, central line complications, the ability to continue to get access, and the fact that to get to a point where you could have a small bowel transplant is 25 pounds and a year of age, and you've got a mother maybe who's not married and still a teenager, and a family unit that will be pretty disrupted by that kind of a life for this little baby. So there you might find that a shared decision-making conversation with a family that had the ability to understand and grasp the concepts would be appropriate. But I can tell you, if there's a 1% chance that you'll have a good outcome, most parents are going to go with that 1% chance, and they will leave behind the 99% chance of, the morbidity and potential mortality that comes with full treatment.
There was another discussion that I remember, and there's a question in CSAP about a patient-centered outcomes trial as it relates to the decisions regarding operative or non-operative treatment of appendicitis. Can you share your thoughts on that with us, and also tell us, is that trial still going on?
It is. So I participate in an 11 Children's Hospital multi-institutional PCORI trial, so it's a patient-centered trial, and we are no longer enrolling patients, but we are looking at long-term outcomes. And so by patient choice, we mean that it is a shared decision-making model where if a child came in with specific criteria that were associated with early appendicitis, so that means an acceptably low white count, proven appendicitis by some imaging study, usually by ultrasound, no fecal ifs, and no obstruction that would portend a recurrence or bad outcome, and some other criteria, that basically we would offer that family the option of operation or no operation in antibiotics. And the child, who could be anywhere from 7 years old or older, had to agree and sign a consent, and the parent had to agree, and then there were quality of life sort of quizzes that were given before they left the hospital. Then there is scheduled follow-up by the lead institution that continues to occur with the long-term goal of understanding what the true incidence is of recurrence of appendicitis in the population that chooses non-operative treatment, with an aim to follow those who are younger until they're 18. The study is ongoing, and once again, it's a model where the patient hears both options. They make the choice of which option they'll follow, which typically allows you to have better enrollment because they feel that they're participating in the decision and not being directed towards one pathway without an opinion about that. And then there's an opportunity at any point to withdraw from the study if they so wish to do that.
Knowing a little bit about informed consent in clinical trials, I just wonder, how hard was it to write the instructions for that discussion without introducing medical bias?
We had a template to follow, and we had monthly meetings with all the new resident groups so that everybody was on board with how the family should be approached. There was a, sheet that we gave to the family so that everybody got the same information. So as far as was within our capacity, it was a standardized approach at every institution to how families were told about the study. And the attending was always involved at the point where permission was gained. And that permission to participate had to be done before the decision was made about which approach was going to be done.
It'll be interesting to see the final report on that one. Okay, well, let's go back to competence, and let's talk about how it works with a child whose family is dedicated to Jehovah's Witness. The 5-year-old needs a blood transfusion because they're hemodynamically abnormal, and without it, the information would indicate the boy may certainly die. And the family is adamant that blood transfusions should not be given to their child. How do you handle that?
It has become a little more straightforward, at least in our hospital, with the implementation of a standardized consent and after meeting with the elders to develop that consent. But there is a lot of precedent for this type of case in the country, and actually the Supreme Court has weighed in several times, and there is a prevailing dictum that when a child's right to live and parental religious beliefs collide, the child's welfare is paramount. There's 3 main points or criteria that prevail. One is that the child's interests and those of the state outweigh the parental rights to refuse medical treatment. The second is parental rights do not necessarily give parents life and death authority over their children. And the third is that parents do not have an absolute right to refuse medical treatment for their children based on their religious beliefs. So rather than try to argue or make it into a controversy, we preface our remarks by saying that we try and make every effort not to transfuse a child. And there are many cases where it's not even something where we would get a blood consent, because in our hospital, and I think most hospitals now, parents have to sign a blood consent for a transfusion. The Jehovah's Witness consent basically covers the unexpected need or potential need for blood, and the language is crafted with the help of the elders such that it releases the parents from feeling that they are causing harm or they've made this decision that is adverse to their religion. It protects the child, if you will, and we've managed to come up with language that satisfies the church and the parents, and they typically sign the consent without any issue. So I don't remember in a long time that we've had to actually go to court to get a court order to do a case.
Let me tell you one of the committee's discussions, and they were surprised at this answer, which is the answer that you gave would be to transfuse the blood products if the child needs them. And the question was, is this universally accepted by the church and the church members? Because there were still some people on the committee who still had a process to get a court order in a relatively quick time period.
Well, I think full-service children's hospitals that have dealt with this in the past and understand that there is a better way to approach it have probably approached it in the way that I explained. Whereas if it isn't a full-service children's hospital and children are not taken care of often, that it might be more challenging. To be clear, there are cases in teenagers where the teenager was felt to have capacity to make their own decision, to understand what being a Jehovah's Witness is and what the ramifications would be of refusing a blood transfusion, for example, in the treatment of leukemia, and where a judge has ruled in favor of the adolescent refusing treatment and the individual ended up dying. So there is precedent for that, and there certainly are conditions that would require the repetitive transfusion of blood products where a decision becomes more pressing and where having some type of ability to understand whether someone is competent to make their own decision if they're a minor is appropriate. There also are a few states where this is easier to do.
Let's move on to another topic that raises emotions occasionally, and that is there are a couple of CSAP questions regarding fetal care. And I guess first, what's your definition, and is the definition clear enough that when somebody mentions fetal care, we all know what we're talking about?
Fetal care is care that's rendered that is not going to benefit the patient in any substantial way, and it typically is something that applies to patients who have a terminal disease such as cancer or a life-limiting disease that has progressed. And the challenge is in helping people to understand and arrive at that understanding so that they can change the way that they're managing the patient. And it's not that they're going to cease doing supportive measures for the patient or treatment for the patient. It's just the treatment will be different.
Can you help listeners regarding how you handle a situation when you feel the care being requested is futile?
Sure. So the place where this usually happens for me is in the pediatric ICU or the neonatal ICU. Perhaps it's a little easier in the pediatric ICU, where you might get a consult for a bronchoscopy or a laparotomy in somebody who clearly is dying. And the providers haven't really recognized that they need a different plan. it's potentially a little awkward for somebody who's never met the patient to come in and try to help with the inception of that discussion. So sometimes I'll just look at the mom or the dad and just say, what are your expectations here? And has anyone talked to you about the real potential here for this to have a bad outcome, or that your child is not going to make it through this? And most of the time, there's a look of, knowingness in their eyes. It's just no one's talked to them about it. It's better if you can recognize that before you get to the point where you're asking a surgeon to do something that's really not a practical suggestion. So my advice is, I call it the appropriateness of care bundles. So we have central line bundles and ventilator bundles. And so here it's sort of 4 questions to ask when you're rounding and you're thinking about introducing a new treatment for a bad cancer or some other disease process. And the first is, what benefit is the patient going to derive from this treatment? The second is, what are the risks of the treatment? Third is, what are the chances of success or failure? And then the pivotal question is, if the chance of harm or failure is becoming greater or over time, or is greater than the chance of success, what does the family want? And am I capable of advocating for their decision if they don't want to do this treatment? Then that sort of brings you to a different set of questions, which is, who should ask them? When's the right time? Who else should be there for the conversation? And respecting the family's wishes for privacy, it still is probably pertinent to ask them who their care group is, or who, if you're going to have a serious conversation about this, who would be in the group of people where you'd most like them to understand a conversation about Johnny and what's going to happen to him, and involved in your decision-making process. And then you go to a room and you sit down with a care group. So we would include our palliative care program, which we call them Hearts and Hands, and anybody the family wanted to be there, and we'd have all the providers involved in that child's care come together for a meeting and just discuss what the options are and how we think things might need to turn to a different strategy. Incremental steps might be needed because families don't always embrace that concept, but you have to understand as a provider that at some point what you're doing is potentially non-beneficial.
Now, it's been my observation that lots of hospitals have developed policies addressing fetal care. And in many of those policies, there's always options that, it sounds very good. Well, if you as the physician doesn't want to do this, you can find another physician to do it. I've never found them to be totally helpful. What's your view on these policies that are usually made up sometimes with a care committee, but many times there's a lot of heavy influence from a legal standpoint?
Are you talking about limited resuscitation decisions?
No, I'm talking about where there's, you go to your care meeting and you don't come out with an agreement even for baby steps, and the treating team feels very strongly that what they're doing is wasting resources, hurting the patient, and the ethics committee is called, and everybody is working towards the same goal, and no progress is being made, and somebody slaps down a hospital policy on the table. That's kind of what I'm hearing and actually experienced in my last institution.
And so the hospital is basically saying you can't continue to do this because it's futile care?
Yes, and here's our policy so that we are justified.
So I'm going to answer it, I think, more as a prophylactic type of opportunity, which is that the introduction of palliative care should begin early so that this is not a stage that you get to where there is an intervention by the hospital to say you can't do this and you don't have agreement with the parties. And so really palliative care is defined as an approach that improves the quality of life of patients and their families who are faced with a life-threatening illness. So it's not necessarily a life-limiting illness or one that they won't survive, but it's a concept that is introduced in the office setting when they first come around, so that you're addressing not only their physical status, but psychosocial and spiritual. You're involving their family and their friends. And so it's a program that actually is recognized by CMMS. It's paid for, and it's something that you integrate into your practice so that people understand what you mean, where you're coming from, and this won't be a surprise if they get to a point where they are facing a life-limiting illness or they're dying and it's time to turn to the next step. I think most hospitals now have a palliative care team because palliative medicine is its own specialty, and that is the ability initially to get a consult from that team where they will help with pain control or providing integrative therapies that will help with improving that patient's quality of life. And then tertiary palliative care is where you move to them taking over and actually managing the patient. So I think the goal is that we as providers understand that this is something that should be integrated into the care plan of people who have complex medical problems that are going to be our lifelong patients or our patients for a very long time, and that we want to do the best thing for them that doesn't just include their surgery, but it's also taking care of their mental health, their spiritual health, their ability to have a good quality of life, and that we're thinking about these things and working with them during their illness, and that we don't get to this point where all of a sudden someone's slapping a policy down and saying, well, you can't do this because it's too expensive and it's not beneficial, because that lacks compassion, and it's really not how we want to practice medicine.
Great comments, Mary. Great comments. And I would just add that our trauma service has engaged our palliative care service so that many times when we have a devastating injury that everybody is aghast at, that we are now incorporating them on admission with discussions with the family, so everybody is on the same page right from the get-go. And I would tell you that it has been a positive experience doing that. But I do have another question about palliative care services, which you covered so nicely, and that is, on the general surgery communities, there was a whole discussion link on palliative care, and there were comments by many of the surgeons that surgeons who deal with these diseases are as good as a palliative care service, and we should take a more active role in this. And the implication was that maybe we didn't need a palliative care service.
I disagree. I believe that I am a compassionate surgeon. I've had a special interest in this topic for a long time. I think I'm knowledgeable about it and that I feel pretty comfortable speaking with families about it, but I'm not a palliative care specialist. I haven't studied that discipline, and I believe that having a team that's specialized in taking care of patients at the end of life or before that as a consultant is really the ticket to good medical care. So certainly a complete physician should be a compassionate physician, should understand what that means, should understand what empathy means, and how to put themselves in the role of patient or patient family and try to understand what it would be like to be them. That's true empathy, whereas sympathy is feeling sorry for someone. But we're busy providers who really are not trained to do that well, and it's time-consuming. And I think our patients respect us for being compassionate and for helping them through their illness, but there are experts in this who really should be involved.
Could not agree with you more. And certainly as the disease progresses, they become much more valuable partners in care, as you mentioned, in tertiary care. They really are willing to step in and really help the family right at the end of life for their loved ones. It really is, when it works well, it really is amazing. I've got a professional and ethical dilemma for you. So it's been about 18 months. The question of overlapping surgeries has become an issue. So the first thing is, can you give us a definition of overlapping surgeries?
Overlapping surgeries are best stated as procedures that are scheduled so that as one ends, another begins, and you're trying to economize on optimal use of rooms and surgical teams, but parts of the surgery are going on at the same time, and that may be for a single surgeon or a team of surgeons, and they have one or more rooms operational at the same time. It is much more common in teaching hospitals and medical schools, and the goal is that the senior surgeons, the attending surgeons, are present for the parts of the cases that require their expertise and are the parts where the major portion of the surgery is being performed, and spine surgery is potentially one of the best examples here. But there are other examples. A busy trauma center might have overlapping rooms. So, for example, in the Boston Marathon bombings in 2013, there were many victims brought to the same hospital who required immediate surgery to save their lives. So you had several rooms running, and the trauma surgeons, the attending surgeons, perhaps the chief residents, those with the most expertise were going from room to room and providing the life-saving parts of the procedures while others opened and closed the cases. Obviously the anesthesia was doing what they do at the head of the table with blood transfusions, etc. In elective surgery, it provides for optimal use of rooms, efficiency, access. So it's the ability to use resources in timely fashion and at a time when pathology and the labs and radiology are fully staffed, so that you're actually making the best use of time and you're also taking care of as many patients as you can do safely and with the quality of care that you want to provide. Also, in our day and age of training residents and expecting them when they finish their training to be able to go out and engage in the practice of surgery and be autonomous, it gives them the opportunity to have graded autonomy under the supervision of an attending physician. So this would apply to both residency programs and fellowship programs, where you, in many places, would credential the fellows, who are usually board certified in some specialty, to begin the case and end the case independently, but during the parts of the case that require supervision, they would have the ability to have the attending surgeon there to help them to perform those parts of the case. So I think the issue comes in as to when overlapping surgeries become concurrent surgeries, concurrent being that the important parts of the case are running simultaneously, which is not the intent of overlapping surgery.
That's my next question. I'm glad you laid out the overlapping surgeries in a way that it sounds like it truly is a win-win for a lot of different constituents. So what about when it's not overlapping but concordant? What's the worry there?
Well, the worry is that you will have an important part of a case that is either on hold because the surgeon is not in the room and can't continue the case, because they're busy elsewhere in another room, or someone who is not competent to do that case is doing the surgery without supervision, and something happens that results in an adverse outcome. So I think if you're going to have this type of plan, it is better if it's not a single surgeon, it's a team of surgeons, or else you have to have a backup plan for someone who's going to come over and participate if the primary surgeon is unexpectedly held up in a room and there is a need for he or she to be in another room at the same time.
Does your institution use both types of scheduling, and how does your institution handle them if both types are used?
We will do overlapping surgeries in some cases. Let's say that I'm on call and it's really busy. If we have 2 rooms available, but this is a children's hospital, so I have to have seen the family. We have to fill out our own consent with what it's going to say, so no one can get our consent. So I have to have seen the family. But what I do is just say, it's really busy. They've given me 2 rooms. And so when I'm finishing up in one room, they're going to bring your child in and put them to sleep. And you may see me in the waiting room talking to the other family while your child is going to sleep. But I need to tell you that I'm doing your child's surgery. But I don't want you to be confused because you see me in the waiting room speaking with another family. So it's truly overlapping where that child is not being operated on anyone but me, but we're running 2 rooms so that we can be more efficient.
So this has to be clearly identified in the consent process then?
Well, I tell patients that's what's happening because I think that's the right thing to do. I think ethically it's appropriate to let people know that's happening, and it's the right thing to do. Does everyone do it? Probably not, but I think the ethical thing to do is to tell them up front this is what's happening. As teaching physicians, now on the Surgery Residency Review Committee, we are supposed to tell parents who's participating in the surgery and what their role is. I've even seen residents come up at times and introduce themselves, and you say, I'm, Dr. So-and-so, I'm a surgery resident, I'll be helping Dr. Fallett do this case. So I think that it's appropriate for them to know what is going to happen in the operating room.
Well, one more issue on this, and that is that when this question came out and the differentiation of overlapping and concurrent surgeries was clarified, especially by the American College of Surgeons, we now have data about overlapping surgery that suggests that the outcomes are not different. Do you think the data that has been generated in the last, and it has only been about 18-24 months, is strong enough to say this is a non-problem for surgery?
I've looked at the papers, and the ones that have been published seem to have been done with both ethical issues in mind, and it seems like they've been done appropriately. So it's, I think, a question if there's still a gap between what is written in the papers and what is done in practice at all institutions in the country. So again, I think if someone's listening to this and they do overlapping surgeries, the right thing to do is just describe to the patient what exactly is being done in your hospital before they come to the hospital that day, so that if they do not agree with that philosophy, then they will either choose another surgeon or the surgeon will choose another way to take care of them the day that they come for their operation.
While we've touched on a number of pediatric ethical questions, I've got one pediatric surgery question that I want to throw out to you and have you help clarify for us general surgeons who sometimes are faced with a neck mass in a child. So what do I need to know?
So are you a general surgeon in a rural hospital who's seen a child and...
I am.
Okay. So when you see a neck mass in a child, there's a differential that comes in groups. It can be congenital, it can be infectious, it can be oncologic, it can be an endocrinopathy. So most general surgeons are going to recognize something that involves the thyroid gland, and they would ask the usual questions about hypothyroidism and hyperthyroidism. Typically, they're probably going to send that patient on to somebody who has expertise or to a pediatric endocrinologist somewhere. If it's infectious, it's likely to be high cervical in most cases, and most kids will have had strep throat or an ear infection or a rash on their scalp or something that is in proximity to when that node appeared. And I have been struck with how long nodes last in a kid. Then some of them have chronic adenopathy. And so you ask the usual questions, and if it's, a centimeter or less, I think you do nothing. And if it's symptomatic, like it's sore or something like that, and it stays there for a long time, you could excise it, and most of the time it's going to be something, a reactive node. But if it's troublesome, you just take it out. And if it's more than a centimeter and it has the characteristics of what you see in an adult that you're worried about, then you'd either do an FNA or you'd biopsy it if you were worried that it was some type of cancer. Usually the Hodgkin's and non-Hodgkin's lymphoma, they're pretty striking. They're just like you'd see in an adult. They don't move. They're supraclavicular. They're firm. Sometimes the patient has B-type symptoms, and sometimes they don't. And you get a chest X-ray to see if they have a mediastinal mass or not. And again, if you're in a place where you don't have tertiary care, you're going to send that patient with their chest X-ray to a specialist to be seen. Quite honestly, I don't know that you would even do the biopsy where you are because there's no reason to do that because you're not going to treat it. If it's congenital, so most common congenitals are going to be thyroglossal duct cyst. That's going to be in the midline, about at the level of the hyoid bone, so high in the neck. If the kid sticks out their tongue or swallows, it should move. They usually show up after an infection or, sort of 2-3 years old. You're probably not going to operate on it, but if you had any thought of doing that, you have to take out the mid portion of the hyoid bone. Why? Because when the thyroid is forming, it forms at the base of the tongue at the foramen cecum. It descends in the neck to its usual position. As it's descending, there's a little stalk from the foramen cecum to the thyroid called the thyroglossal duct. It's supposed to obliterate before the hyoid bone forms, and if the hyoid bone forms first, then it gets trapped. It traps the duct, and that's why you have to take out the mid portion of the hyoid bone, because if you don't, it's going to recur. So either you need to know how to do that operation or you shouldn't take it out. And then the last is a branchial cleft cyst, so those usually show up laterally. Sometimes it's a little sinus draining saliva. Usually pediatricians see that little sinus when the kid's born. Shows up anterior to the anterior border of the sternocleidomastoid muscle, drains a little clear fluid. Pediatrician says, oh, that'll go away. Never goes away. They come in about 2 years old, and that requires you to ellipse that out and trace it up all the way up to the carotid. So if you don't do that operation, you probably shouldn't do it. You should send that on, but it's a real entity, and it does need to be excised. And then branchial cleft cysts usually show up in about the same location, and the second type is the most common type, and they show up sort of anterior to the anterior border of sternocleidomastoid. And a lot of times they don't have any connection, and you just excise them in their entirety. But the ones you have to be more concerned about are the ones that are sort of on the lower face, because those are type 1s. They track through the parotid. They exit in the external auditory canal, and they need a big operation with a parotid facial nerve dissection.
We have a CSAP question about a lingual thyroid, and the question indicates or suggests that these people are usually hypothyroid. Is that true, and what do you have to watch out for if somebody shows up with a lingual thyroid?
I just actually had a patient like this who turned out to have hypothyroidism on their newborn screen, and they got treated, and then they must have had a normal test at some point because they stopped being treated, and then showed up to the endocrinologist with a mass at the base of the tongue and were hypothyroid. So this patient's on treatment, and we haven't done anything yet. But, I mean, if you think about it, if you have to take medicine anyways, why have that thing at the base of your tongue? You're probably just going to take it out, and they'll be treated with their thyroid medication, and they'll feel pretty normal on thyroid replacement hormone.
When I read the critique and started thinking about this, do they ever enlarge to where they can cause airway obstruction or even esophageal obstruction?
Well, I think this patient was developing a goiter of types because they weren't on thyroid medication, so she became a little dysphagic. But when she got on thyroid medication, she started to feel better. So at this point, we haven't done anything because I think it shrunk back down.
Interesting. Okay. Well, I see that our time is about up this afternoon. It really has been a pleasure spending time with you, as usual, to discuss many of the CSAP-17 topics. I just ask you, any closing comments about CSAP or CSAP Audio Companion that you'd like to share with our audience?
I have enjoyed participating in it. I think it's a good time for me to sort of review things and review how I've practiced in the last 30 years, and also just to provide some comments to the listeners about how you interpret things from the point of view of the patient, because it's really important. And with the advent of the EMR, we're spending less and less time with patients, so I think it's really important to remember that that's why we're here, is to take care of the patient. I've really enjoyed it, and I am amazed. I'll travel through the country and I'll see residents who I've trained, and they'll say, Dr. Fallett, I heard you on CSAP when I was studying for my in-training exam or studying for my board. So people really do listen to it, John. So I think you need to continue it.
Well, I hope we keep asking the right questions to help all those young trainees. And with people like you on the other end of the table with our discussion, I'm sure we're asking the right questions. So I thank you very much for your contributions, and I hope you have a great rest of the day.
Thanks so much.
That's it for this category of the CSAP-17 Audio Companion.